The doctor will ask the patient to walk in order to observe and evaluate their gait cycle. As they walk across the room, the doctor assesses symmetry and turning ability and notes any signs of pain or discomfort. Now, the doctor will ask the patient to walk with few modifications. First, heel to toe, where the toes of one foot must touch the heel of the other foot. The doctor notes in case of an unsteady gait, indicating ataxia. The next step is asking the patient to walk on their toes. Finally, the doctor will ask the patient to walk on their heels. This is to check for any corticospinal tract injury. Hemiplegic gait. The patient presents with a unilateral weakness. The leg on the affected side is extended and in internal rotation. On the same side, the shoulder is adducted, elbow is flexed, and wrist is pronated. Interphalangeal joints are flexed, thumb is in fist. The movement consists of circumdiction in a semicircular pattern. This is due to weakness of distal muscles, as in foot drop, and extensor hypertonia in the lower limb. The other side of the body has a normal range of movements. This is probably a sign of a stroke. Diplegic or spastic gait. Both sides of the body are affected, with the more severe spasticity in the lower limbs than the upper limbs. Hip and knees are flexed. Ankles are extended and internally rotated. The knees are adducted and cross the midline, pattern known as the scissors gait. This is due to an extreme tightness of hip adductors. Patient walk in an irregular narrow base, dragging both legs and scraping the toes. This is typically seen in spastic cerebral palsy. Steppage, equine, or neuropathic gait. This gait may involve one or both legs. The patient cannot walk on their heels. To compensate, they either drag their feet on the floor or lift them high in an exaggerated manner, their knees being flexed, and then slap their feet onto the floor. Choreiform or hyperkinetic gait. Here, the doctor typically witnesses jerky involuntary movements in all of the patient's extremities. However, having their balance unaffected, the patient doesn't fall. This is especially seen with some basal ganglia disorders, of which Huntington's disease. Ataxic or cerebellar gait. Patient cannot stand still with their feet together, whether their eyes are open or closed. The doctor asks the patient to walk in tandem. Gait is staggering, unsteady, and wide-based in an effort to maintain balance, with exaggerated difficulty on turns. It is seen in cerebellar disease, where we witness pronounced coordination and balance difficulties alongside other cerebellar signs. Sensory ataxic gait. Gait is unsteady. Patient must watch the ground when walking. They walk with feet wide apart, throwing them forward and outward. And you can hear a double tapping sound as they bring them to the floor, first on the heels, then on the toes. This is due to a loss of the valuable proprioceptive input, demanding extra effort from the patient to locate their feet and control their landing. This gait can indicate a dorsal column disorder or a pathology in the peripheral nerves. Antalgic gait. This is the most common form of abnormal gaits. The pain leads to a limp where the stance phase is shortened compared to the swing phase. Trendelenburg gait or gluteus medius lurch. The Trendelenburg gait, also called gluteus medius lurch, is caused by a unilateral weakness of the hip abductor, namely the gluteus medius muscle. During the stance phase, the gluteus medius muscles maintain both hips at the same level. However, in a positive Trendelenburg sign, the doctor will see a drop of the pelvis on the unaffected contralateral side, as it tilts downwards instead of upwards. This is compensated by a lateral lean of the torso, away from the affected side. This excessive lateral tilt will help maintain the center of gravity over the stance limb, leading to a reduction of the pelvic drop. Myopathic or waddling gait. Here, the patient has a bilateral weakness of the hip abductor muscles, leading to a waddling motion with the pelvic drop on both sides when walking. Parkinsonian, festinating, or propulsive gait. This gait is typically seen in Parkinson's disease and with other conditions that lead to Parkinsonism. The patient has their head and shoulders bent forward and their knees flexed. The entire upper extremity is flexed too, and the fingers are extended. There may be difficulty in initiating steps. Once initiated, the patient walks in slow and small steps. Tremor may also be associated. The festination consists of involuntary acceleration of gait in an involuntary inclination. The patient turns en bloc, that being turning the head, trunk, and pelvis as one single unit.